Great. Welcome back, everyone. Our next speaker is Dr. Saeed. Dr. Saeed is a nephrologist and a palliative care physician. He runs a kidney palliative care at the University of Rochester, New York. His research work involves testing palliative care and communication interventions to improve dialysis decision making for older adults with chronic kidney disease. And Dr. Saeed, welcome. Thank you for joining us.
Thank you. Thank you, Dr. Zhang. Uh, Earlier this year, I saw Mr. James. He was in his 80s. He was tall. He was sturdy. He used to work as a mechanic. He had CKD for a long time, but he never made a decision for or against dialysis. Gradually, his kidney disease kept getting worse, and he also started developing dementia. Over time, his dementia also started getting worse, so much so that his only daughter, Lori, moved in to live with him so she can take care of him. Gradually, Mr. James started developing behavioral disturbances. One day, he pulled out a knife on his own son in law of 25 years and started yelling, "I want you to get out of my house." Lori had no choice but to call Adult Protective Services. They came, did an evaluation, and Mr. James was totally calm and quiet by that time. Nothing happened. Things kept getting worse from both dementia standpoint and kidney standpoint. Lori felt quite burdened by the whole situation. During the last visit with Mr. James's kidney doctor, the kidney doctor said to Lori that they needed to make some decisions about dialysis. Lori had no idea what to do. She intuitively knew that probably dialysis will not benefit her father, but she also wanted to give her father a fair chance. She felt very burdened by this decision. She wished she would have had these conversations with her father. She wished her father had an advance directive in place, but he didn't. So, advanced care planning is the most loving thing one can do for himself and his or her family. Advanced care planning is the topic of today's presentation. The broader objective of this talk is to understand the difficulty and importance of having end-of-life discussions with patients and family members. This is the roadmap. Over the next 35 minutes or so, I will start with talking about what is advanced care planning, why is it so difficult to engage in this process, and do the family members know the end-of-life wishes of their loved one. And in the final part of this talk, I will focus on components of advanced care planning that are relevant for patients with chronic kidney disease or ESRD. So what is advanced care planning? It's a message to the future. It's a process of discussion and planning by a competent person addressed to their future clinicians, expressing their wishes and preferences regarding medical treatments in the event of becoming incompetent. Advanced care planning holds the weight of law and is enforceable. The documents that are produced as a result of engaging in advanced care planning are called advanced directives. They should be made by a person with capacity, and they express a decision that will be implemented at a future time when that person is has no longer capacity to make a decision. Why shall we care about advanced care planning? The latest study from one of the most prestigious journals on a study done over hundreds of years has told us that 100% of us will die one day. Evidence-based medicine. Additionally, we know that for dying people, respect and dignity matters the most. But Almost 2/3 of the older adults facing end-of-life decisions are incapacitated, and if their wishes are unknown, by default, they receive more invasive and potentially burdensome treatments. However, if they've engaged in advanced care planning process, they're more likely to have less painful dying process and less emotional distress. They're more likely to use palliative care and hospice services and have more control over the dying process. As a result, bereavement outcomes are much better in family members. So what are advance directives? There are two types of advance directives: decisional and appointment directives. Decisional directives include living will and most. Appointment directives include healthcare proxy and a durable power of attorney. For this presentation, we will not be talking about the durable power of attorney that deals mostly with financial aspects. So what's a living will? It's a legal document prepared by lawyers where patients can articulate their wishes regarding end-of-life treatments. Sometimes it's not readily available in medical records. Language can be vague, and studies have shown that there's a less chance for a living will to be followed during the end-of-life course of the patient. Most, on the other hand, is more specific, more likely to be followed than a living will, more readily available in electronic records, and no lawyers are involved, and a clinician can fill it out. This is the most form. In some other states, it's called post. It talks about issues such as CPR, DNR, comfort measures only, intubation, hospitalization, IV fluids, antibiotics, and then there's a section on other instructions where decisions regarding dialysis can be mentioned. The third form of advance directive is a healthcare proxy, where someone appoints a person as the decision maker for future decisions when that person, when the patient's no longer able to make decisions for himself or herself. Being a healthcare proxy is a loving, burdensome, and a meaningful responsibility. Advantage of a healthcare proxy, or let me rephrase, advantage of a good healthcare proxy is that he or she can make in-the-moment decisions based on real data. But the assumption is the healthcare proxy knows patient's wishes. But do they really know patient's wishes? So this question was answered by Dr. O'Hare's study published in Clinical Journal of American Society of Nephrology, where she and her team did a survey on 1,000 dialysis patients. They identified family members by asking the patients. Family members were in turn contacted over the phone, and the broader purpose was to understand if family members had knowledge of patients' treatment preferences, values, preferred decisional role, and prognostic expectations. These are the demographics. You can see here, mean age of patients is 61 years, family members 55 years. Majority of the caregivers were women. There was appropriate representation of all the races in the study. However, the study sample comprised patients and family members who had relatively higher education level. 40% of the caregivers were spouses, 60% lived with the patient, 66% said that they spent most or all the time taking care of the patient. Almost 70+% patients felt extremely or quite a bit confident that they knew patients' wishes. We gave patients these questions, and we gave family members several similar questions as well. We asked family members if they had spoken with the patient about who's going to be the healthcare proxy. 80% said yes. We asked family members about presence of advance directives for the patient. 41% said yes. patient preferences regarding uh, values around life prolongation. 53% said that they had uh, spoken with the patient about these values. Preferences regarding different treatments, 63% said yes. Conversations about stopping dialysis, 27%. Conversations about hospice, 32%. Remember, we had given patients a survey about their values around different end-of-life scenarios, and then we had asked family members, what do they think are patients' wishes? So then on the patient and family responses, we ran Kappa statistic, which sort of tells the agreement between patients and family response, sort of agreement between how well family members are, how well family members know about the patient's wishes. Which patients' wishes about CPR, family members had only sort of like a fair idea. Intubation, slight idea or slight agreement. Values around life prolongation, slight agreement. Values around preferred place of death, slight agreement. Preferred decisional role, slight agreement. Prognostic understanding, slight agreement. So almost in all domains, family members had fair to slight idea of what the patient wanted. They lacked detailed understanding of patients' wishes. And we found similar trends in healthcare proxies and those who felt confident in knowing patients' wishes. Again, just to highlight, conversations about hospice and dialysis discontinuation were held between patient and family members only 1/3 of the time. So family members really don't have much idea in general about patients' wishes. Invariably, they find it difficult to let go. They project their own wishes onto the patient. And the truth is, the healthcare system also does not involve family members in these conversations. Let me give you an example. A few years ago, my mother, who's approaching her 70s, made a statement. I don't know how long I'm going to be with you all. As soon as she said that, my siblings and I, we immediately said, no, Mom, you'll be okay. As soon as I said that, I realized that my mom was opening a door to have conversations about her end-of-life care. And I did not let her open that door. I felt really guilty. I was a trained palliative care physician at that time. End-of-life conversations is something that I do on a routine basis. But it was still difficult for me because this was my mother. And it's difficult to have end-of-life conversations about your own mom's death. But I mustered up my courage. Months later, during an evening walk, I said to my mother, Mom, and this is in Urdu, which is my native language, I said, Mom, how's it possible? One day we're here in this world, and the next we're not. My mom accepted that invitation. She opened up. We talked about death. We talked about dying. We talked about her end-of-life wishes. So in a way, my mom gave me a gift by letting me know of her end-of-life wishes. But I had to be ready to receive that gift. And a strange thing happened after having that conversation with her. I became less afraid of her death. Rather, I became committed to honor her wishes if her time comes before mine. So it's difficult for family members to engage in these conversations with their loved ones. What about patients? This is a study we did at the Cleveland Clinic at 7 dialysis units. There were almost 423 patients who participated in the study. 71% said that they were comfortable having end-of-life discussions with their family members. 63% were comfortable having end-of-life discussions with nephrology staff. 67% had thought about their illness course in the future, but only 10% recalled having prognostic discussions with their doctor, while 78% thought it was important to be informed about prognosis. Regarding advanced care planning components, 35% had a living will, 20% a mulched form, 8% a healthcare proxy, 21% a power of attorney, while 46% didn't have any of those documents or did not know. So patients want to have these conversations, but they're not given an opportunity to engage in these conversations. We all have a stable relationship with the fear of death as we age. By age 62, studies have shown we all sort of have like a clear relationship with death. So really, and other studies in octogenarians have shown that death-related anxiety is almost negligible in octogenarians. But issue in my mind is not fear of death, especially for older adults, or at least many older adults, is that patients don't understand what is advanced care planning, what issues they need to make decisions about. They think it's physician's responsibility. And then there's inherent tendency to delay these heavy decisions. On the other hand, it's very difficult at so many levels for physicians to have these conversations with their patients. Every time a physician talks with the patient about the patient's death and dying process, physician's exposed to his or her own mortality. And that discomfort causes the physician to not engage in these conversations. We're not taught to have these on how to have these conversations with patients. Clinics are busy. We lack time. Dr. O'Hare did a study asking nephrologists who should be doing advanced care planning. Nephrologists said patients. Then she asked primary care physicians. Primary care physicians said that this is a nephrologist's job. So we really don't know whose job is it. There's uncertainty about prognosis. And there's also fear that by talking about these things, we will somehow deplete hope. I remember in 2013, when I started my first job as a nephrologist, I participated in a family meeting to help a patient decide about dialysis. Now, this patient had end-stage liver disease, and my colleagues and I, we kind of knew that this person will likely not do well with dialysis, but neither my colleagues nor I ever discussed his prognosis with him. The option of not doing dialysis was never discussed. Eventually, this person was started on dialysis. Following that, he had several admissions related to various reasons until he finally died at a hospital. This patient and several other patients like him made me realize of my inadequacy in having these difficult conversations with my patients. And for that reason, I left my first job and decided to do a palliative care fellowship. But this story is not unique to me. When we surveyed 142 nephrology fellows, the top reason for moral distress was issues related to futility and end of life care. Higher moral distress was associated with thoughts of leaving nephrology fellowship. So physicians, we feel afraid to have these discussions, but we also feel morally distressed when we're not engaging in these conversations. So the bottom line is start somewhere, you know, uh, be courageous and start somewhere and have these conversations with the patients. So far in this presentation, we've talked about three different forms of advanced directives. We've talked about three different levels of advanced care planning. We've talked about that it's difficult for family members to know patients' wishes because of various reasons. Patients want to have these conversations in general, but physicians are not trained or not comfortable in general to have these conversations uh, with their patients. So, what are the issues relevant to completion of advanced directives for patients who have advanced CKD or are on dialysis? First of all, we need to acknowledge that end of life course for our patients is very burdensome. 63% are admitted to ICU in the last 3 months of life. The cost of end of life care is higher in comparison to patients with cancer or heart failure. On average, 5 different specialists see these patients during their last 90 days of life, and the hospice enrollment rates are around 23%. So we need to improve end of life care for our patients. Because it's the right thing to do, and also by law and by society guidelines, we're kind of mandated to offer uh, our patients an opportunity to complete advanced directives. So what are the components of advanced care planning for patients with advanced CKD or uh, who are on dialysis? We'll talk about 5 different things. One relates to timing of advanced care planning and who are the candidates for advanced care planning, why it's important to discuss patient goals, importance of communication skills, prognostic data on outcomes of CPR, then we'll briefly touch on uh, issues related to withdrawing and withholding from dialysis. We will not be talking about issues related to feeding tube, IV fluids, and hospitalization. So when shall we start engaging in this process? The bottom line is whenever it feels right. But there are several time points during the illness course where advanced care planning the process could be initiated. At the time of diagnosis of CKD, at the time of dialysis initiation, or at any change in the health status. Who are the candidates for advanced care planning? Everyone, but in particular those who have limited prognosis, advanced age, higher burden of comorbid conditions, who are frail, have poor functional status, or they're likely to die within the next 1 year or so, in the opinion of a clinician. But the whole process should be guided by patients' preferences. Last year, or maybe a couple of years ago, when I was on palliative care service, I was asked to see a patient who was refusing dialysis. I entered the room, and there I saw a very good-looking woman with very bright, shiny eyes, thick, long hair, laying in her bed. Her name was Betsy. Betsy was 81 years old. She had end-stage cardiomyopathy. She had poor functional status and her GFR was 10 ml per minute. I asked Betsy about her understanding of her kidney disease. Betsy told me that she knew that her kidneys were working at a very low level. She said to me that she did not want dialysis. I asked her why. Then she told me a story. When Betsy was a child, unfortunately, she was sexually abused by her own father. She left her house during her teenage years. She later became a chaplain, but she made a promise to herself that in her capacity as a human being, she'd make sure that no other child goes through what she went through. So she took care of 73 foster kids. She adopted 3 children. She raised them as her own children. All were grown up now. And Betsy said to me, "Look, Dr. Saeed, I can't walk. I have end-stage heart failure. I don't think so. This is the life worth living. I have achieved my life goals. I have a good sense of life completion. I don't want dialysis." She further said, "All my life, I've done things for other people. This is the only decision I'm making for myself." So patient values matter, their preferences matter, their stories matter, and that should be the guiding star for advanced care planning process. These conversations need to be done with vulnerability, courage, sensitivity. Physicians, clinicians need to be aware of their own emotions, their own relationship with death. Truth telling needs to happen. Optimism needs to be maintained. Attention to what is being said and what is not being said needs to happen. So these conversations are gentle, fluid, sensitive, but never forceful. Delivery of prognostic information is also a part of these conversations because we want to give patients a fair chance of choosing between different treatments. So I will talk about prognostic data on CPR and dialysis, especially for older adults. In our study of almost 56,000 dialysis patients, 74% died after receiving in-hospital CPR. Odds of mortality in dialysis population was almost 24% higher than the general population. Only 1/4 of the survivors were discharged home, and patients with ESRD status had higher odds of being discharged to nursing homes. Dr. Wong, in her JAMA paper, showed that majority of the survivors, they survived only for 5 months after getting discharged from the hospital. So these are important prognostic data that could be presented to patients while having these conversations. Patients who, in physicians' opinion, will likely have poor prognosis, but they still want to receive CPR because life's precious. A trial of CPR can be discussed. This is our work where we showed as the duration of CPR goes up, mortality goes up. In my mind, a trial of CPR for 20-25 minutes will give patients probably a fair chance of survival. But beyond that, odds of survival get really low. But each case is unique and individual. But at least these data can be part of the conversations related to trial of CPR. For older patients with advanced CKD, dialysis decisions need to be documented in advance directives. There's a growing body of literature in this area. I'm going to present only one study by Channa et al., who compared survival between dialysis and conservative kidney management or no dialysis option. In dialysis group, they had 689 patients. Mean age was 59 years. 17% patients had a higher number of comorbid conditions. In no dialysis group, there were 155 patients. Mean age was 68%. Almost half of these patients had a high number of comorbid conditions. No surprise, survival with dialysis was much better than no dialysis options. 67 months versus 21 months. Survival was better if patients were younger, didn't have diabetes, and had fewer number of comorbid conditions. Again, in patients with lower burden of comorbid conditions, survival with dialysis was much better, but this survival advantage was lost in people who had a higher burden of comorbid conditions. And for older, frail people, even if there's some survival advantage with dialysis, majority of that time is spent at dialysis or in the hospital. This is the trajectory of functional status for an average dialysis patient. You can see here, after each hospitalization, functional status declines and keeps declining until the patient dies. In comparison, patients who choose against dialysis, they maintain their functional status until a month before they die when there is an acute decline in their functional status. So conversations about foregoing dialysis or decisions about dialysis also need to be documented in the MOLS form or the living will. But other than that, conversations about withdrawal from dialysis also need to be a part of advanced care planning for patients on dialysis. This is the story of Mr. Dreyer. He was from Canada. He was a 60-year-old widower and father of two who spent his career designing the exterior walls of skyscrapers. He was not a candidate for transplantation and had been on dialysis for some time. He said, "I've stood 790 feet in the air on bamboo scaffolding. Not a whole lot has scared me. One thing that I have a phobia about that just turns me into jello, and I can't stand it, is needles." Dialysis, he said, was like saying to a snake-phobic person, "Here, hold this snake 4 hours a day, 3 days a week." Of course, crippling needle phobia was far from the only reason Mr. Dreyer did not appreciate dialysis. His health had been relatively poor for several years. Additionally, his beloved wife of 32 years, Vicky, had died suddenly 2 years earlier. His business had failed. He was broke. Above all, he abhorred the thought of becoming a burden to his children. He said, "My kids are like, Dad, we will tear our lives apart and live with you and take care of you. I spent 30 years getting them to the point they're at. Why on earth would I do that to them? And for what purpose? To extend my miserable and painful existence?" God blessed me with kidney failure, Mr. Dreyer said, because it's an on and off switch. It gives you the power to die when you're ready without applying for physician-assisted death. All he had to do was tell his doctors that he was finished with dialysis and he was free to go. On December 17, 2019, at 11:45 p.m., he died 12 days after stopping dialysis, after flicking his own personal off switch. So in the last 34 minutes, we talked about components of advanced care planning. We talked about what are different forms of advanced directives. We talked about living will. We talked about MOLST. We talked about healthcare proxy. I tried to emphasize the point that although advanced care planning is difficult for both physicians and family members to engage in, but it's the most respectful and dignified thing one can do for patients and family members. Advanced care planning is likely correlated with a better end-of-life course, and it needs to be person-centered, guided by patients' preferences and prognosis. Other than decisions about CPR, tube feed, comfort care, hospitalization, IV fluids, antibiotics, unique aspects of advanced care planning for older adults with CKD who are on dialysis. Older adults with CKD are decisions regarding foregoing dialysis or withholding dialysis or withdrawing from dialysis. These were the different issues we discussed. Now with that, I will take any questions you may have. Thank you.
Great. Thank you so much, Dr. Saeed, for a wonderful, wonderful talk. Here you go. Wendy Grainer asked question, why does each state require their own advanced direct form? I think it would be better to have one from accepted by all states. For instance, a patient moved to Nevada from another state, and we have to have him complete a Nevada paperwork.
No, Wendy, you definitely raise a good point as a policy level issue, but in practice, as you're aware, even advanced directives from another state, at least they're meaningful. They give you some clinical basis. They give you some starting point for having conversations with the family members and knowing the patient's wishes. But you're right, though. I also wish all the states had only one type of advanced directives.
Great. And Wendy has another question. She said, quote, I feel very comfortable talking to our patients about completing advanced directive. I'm fairly young and have had one for 8 years. I use this information as a tool to discussing the material. I discuss with them that it's important to know what they hold value when I come to their health. I also tell them it's similar to car insurance. We have it and may never need it, but if needed, it's there to help us. Oh, that's her comment. If I may, I will say this is similar to car insurance, but not because we are going to use it 100% of time. Uh, that's just my comment. Hopefully, sorry, I shouldn't say that, but Dr. Sai, what's your comment on
No,
that?
I appreciate that you're comfortable having these conversations with the patients, and there's just no perfect way of doing it. You just gotta start somewhere, and I'm very glad that you give this gift to your patients, that you're comfortable having these conversations.
Right,
That's definitely something to applaud.
right. Mira has a question about for the study on dialysis patient receiving CPR, do we have a breakdown of likelihood of survival based on age group, or was it standard across all age group?
Uh, if I recall correctly, uh, we also looked at some other factors that were related to poor survival, and older age was definitely one of them. In the other study where I showed the correlation of CPR duration with survival, there were two factors, two variables that were associated with poor survival. One was increasing duration of CPR, and other was increasing age. So survival is poor, relatively poor with advancing age.
Okay. And follow-up question is there any difference between patients on home modality versus in-center hemodialysis regarding CPR?
It's my understanding that no, there's no difference. But having said that, as you know, that we don't have a lot of patients on PD, and the study I showed you from the nationwide inpatient data set, uh, I don't know if we made that distinction or not. Uh, I couldn't tell you with 100% clarity if there's any difference, but my hunch is that there's no difference, if I recall that correctly.
My personal experience, since we have 30% of patients on PD in Kaiser, Northern California, vast majority of our patient elderly at the end of their life, they either has advanced directive, decide to stop dialysis, they pass peacefully at home, or they so sick not able to do PD transition to hemo, end up in center, and a lot of them passed away in the hospital because they're hospitalized for infection. So probably it will be very hard to do study compare PD versus in center hemodialysis.
Mhm.
Um, Stephanie has a question. She asks, I wasn't aware that one could choose to have a trial period of CPR. How is this typically worded in the post or most? Would it be honored by the paramedics?
If the post or most is posted on the refrigerator door, and the way I typically do it, I write it next to the CPR section, that CPR only for 10 minutes or 15 minutes or 20 minutes. And then ideally, the paramedics should honor that. And ethically it's acceptable. Dr. Timothy Coyle, who's one of my mentors and also here from University of Rochester, he had a JAMA paper on that. So uh, it for some people it's burdensome to say no. They want to take a chance, and it's ethically appropriate to give them CPR if it gives them reasonable chance. Some people say 3 or 4 cycles are enough. We've done that in clinical settings. For dialysis population, based on these data, uh, my feeling is 20-25 minutes is enough.
Great. Um, there's no more chat question, but I do have a question. Sometimes family member were not on a post or most. How do you manage those situations?
It's a morally distressing situation, uh, which needs to be dealt with extreme self-awareness, and at the same time compassion for the self and for the family members, because really family members are trying to do the best they know is the best for the loved one. uh, as I alluded to in my presentation, that the psychological defense mechanism of projection plays a role, where family members you know project their own wishes onto the patient. So there's this technique, the empty chair technique, where which one could uh, apply in these settings. So the way it works, you have, let's say there's a family member who's the healthcare proxy, you as a physician, and then you have an empty chair in the third empty chair in the room, and you say, okay, if Mr. So and so or Miss So and so had full capacity and was sitting in this chair, what do you think? What would she say? And then suddenly that breaks that projection. And then they can say, oh, mom will say no. Oh, she'll say no, but you're saying yes. So then, they realize, and most of the time, they really want to do the best for their loved ones.
Right. Yeah, we are at time, but can I follow up quickly on this? Sometimes my experience is many family members, they consultant who take care of that patient really know what they want. There's always somebody out of town, family member who hasn't take care of this person for a long time. They come in, they feel very guilty about they are not taking their mom, dad for a long time, and they just want full press, everything. Then there's a conflict between the family member. How do you do it skillfully, avoiding this conflict within the family member?
Right. These situations, Dr. Zhang, as you're very well aware of, they are morally distressing, they're frustrating, and they're very difficult. There's conflict among the family members, and that conflict is not new, by the way. It has always existed, but in the stressful situation, it just becomes very prominent. Uh, oh, uh, oh, there's some feedback. Okay, anyhow, so there's no easy answer.
Sorry. Hold on. I'll unmute myself first.
Okay, so there's no easy answer here. The one technique that could be applied is engage all the family members. Here, listen to each family member's perspective. If there's an advance directive in place, open that advance directive, read that, and invite perspectives, and with compassion, and if families are being listened to and they feel they're heard and understood, then there's a chance conflict could be resolved. Uh, there's a chance conflict may not be resolved, and then that's something that we'll have to be okay with, because we can't win each time. So it's a sad situation, though. Anger is common, conflict is common, past comes in, so it becomes complicated.
Great. Thank you so much. Thank you.
Thank you.